Hello everyone, I'm Prasad Katimani. Today I'm going to briefly talk about hemolytic uremic syndrome. So by definition, HUS is a disease of triad which is characterized by hemolytic anemia, acute kidney injury, thrombocytopenia. It mainly affects children, but it could also affect the adults. So there are three different types of HUS. One is HUS, which is typical, atypical HUS, and HUS due to complement abnormalities. Classification according to Etiopathogenesis includes two types, typical and atypical. Typical is generally infection related. Infections like Shiga toxin producing E. coli and Shigella, pneumococcal infection, HIV infection, and other viral and bacterial infections. The atypical ones include complement factor related abnormalities like factor H deficiency, factor I deficiency, and other miscellaneous causes like malignancy and drugs. Etiopathogenesis. Typical HUS is caused by enterohemorrhagic E. coli, Shigella dysentery type 1, and rarely HUS can occur secondary to E. coli causing UTI. The common serotype of E. coli causing this infection is O157H7. However, only 10 to 15% of patients with E. coli O157H7 infection will develop HUS. Sources of infection are milk and animal products like incompletely cooked meat, human fecal-oral transmission, and vegetables, salads, and drinking water which is contaminated by animal waste containing this bacteria. Atypical non-diarrhea related HUS is caused by pneumococcal infection, sometimes due to complement abnormalities, and other miscellaneous causes of HUS are abnormalities in intracellular vitamin B12 metabolism, HIV infection, systemic lupus erythematosus, malignancies, radiation, and certain drugs. Other infections related with HUS are viral infections like influenza virus, cytomegalovirus infections, infectious mononucleosis, and also bacteria like streptococcal and salmonella. Typical pathophysiology involves Shiga-like toxin binding to the endothelium in the glomerular membrane. This leads to activation of leukocytes, aggregation of platelets, and activation of endothelial cells. So when this happens, there will be platelet aggregation on uncleaved von Willebrand factor, and this causes microthrombi throughout the body. When blood flows through these obstructed small capillaries, it leads to destruction of RBCs, which forms cystocytes and causes hemolytic anemia, which is Coombs negative. The consumption of platelets as they adhere to the microthrombi leads to thrombocytopenia. It could be mild, moderate, in some cases it could be very, very severe. However, in comparison to thrombotic thrombocytopenic purpura, the kidney tends to be more severely affected in HUS, and the neurological symptoms are less severe when compared to TTP. Clinical features. The commonest clinical presentation of HUS is acute pallor, oliguria, diarrhea or dysentery, which is most of the times bloody. It mainly affects children between the age of 1 to 5 years. Generally, HUS develops 5 to 10 days after the onset of these symptoms. Hematuria and hypertension are very common. Complications of fluid overload may present as pulmonary edema or hypertensive encephalopathy. Despite thrombocytopenia, the bleeding complications are not very common. The neurological symptoms include irritability, encephalopathy, and it could be as bad as seizures. The investigations include full blood count, peripheral blood smears, reticulocyte count, lactate dehydrogenase, bilirubin, eugenase. Urine analysis may reveal hemoglobinuria, hematuria, and proteinuria. As I explained earlier, the blood passing through a narrowed peripheral capillaries leads to hemolysis. This actually leads to fragmentation and destruction of RBCs. When you see on the peripheral smear, what you see is cystocytes, as you see in this slide, fragmented RBCs. Identifying the cause. In patients with diarrhea, the identification of pathogenic enterohemorrhagic E. coli or Shigella is performed by stool culture, further stereotyping by agglutination or enzyme immunoassay. Rarely, HOS can be caused by E. coli causing UTI. In non-diarrheal cases, urine culture is indicated. In pneumococcal related HOS, sputum, CSF, blood, and pus cultures need to be done. Diagnosis. Typically, it is not straightforward to diagnose HOS. HOS and TTP are very identical. The lab features of both of these are very similar, and not all HOS patients, the disease is preceded by diarrhea. So the diagnosis is mainly clinical. When there is hemolytic anemia, thrombocytopenia, and acute renal failure, you suspect HOS. Sometimes the distinguishing feature between TTP and HOS is in TTP there is fever and neurological symptoms, which is not very commonly seen in HOS, but this is not the case all the time. These two diseases are very similar and they are treated as a single entity called TTP HOS most of the times. In TTP, pathophysiologically, there is autoantibodies against IDMTS13, which is not the case in HOS. Management of HOS. The mainstay of treatment is supportive therapy, antibiotics when indicated, plasma therapy, and other modalities of treatment. Supportive therapy. In all patients with HOS, it is very important that you monitor them very closely. Fluid status, blood pressure, neurological status, and ventilator parameters need to be monitored very closely. Blood levels of glucose, electrolytes, creatinine, hemogram need frequent monitoring. The use of anti-motility therapy for diarrhea has been associated with higher risk of developing HOS. So it is best to avoid anti-motility therapy when you think that diarrhea is infectious in origin. With the onset of acute renal failure, fluid status management is paramount and patients may need renal replacement therapy. Antibiotics are indicated when there is suspicion of infections by E. coli, Shigella, and sometimes pneumococci. Plasma therapy is indicated in atypical HOS, which is due to complement factor abnormality and IDMTS13 deficiency. The replacement of deficient factor is done with FFP. Daily plasma infusions of 10 to 20 ml per kilo per day is done, and some patients may need exchange plasma transfusion. In infants with HOS, which is associated with cobalamin abnormalities, treatment with hydroxycobalamin, oral betaine, folic acid can help normalize metabolic abnormalities and which also helps to prevent further episodes. In patients with persistent ADAMTS13 antibodies and poor response to plasma exchange, immunosuppressive therapy includes high-dose steroids, cyclophosphamide, cyclosporine, and rituximab. In severe resistant cases, even splenectomy may be needed. Prognosis: with aggressive treatment, more than 90% of patients will survive the acute phase. About 9% may develop end-stage renal disease. Many of these patients will have long-term renal problems, and many of them may require lifelong dialysis. About 8% of patients with HUS have other lifelong complications such as hypertension, seizures, blindness, and neurological deficits. So, what is the take-home message today? Good sanitation and maintenance of food hygiene can prevent HUS, which is related to infections, diarrheal disease. Supportive care and renal replacement therapy is the cornerstone of management in most of the cases. Non-infective atypical HUS should be treated rapidly with plasma therapy and other immunosuppressive therapy. Efforts must always be made to find the etiology in atypical HUS, as this affects the treatment and the outcome. So guys, I hope you enjoyed today's topic. See you next time with another interesting topic. Thank you.